Evening to all, I am Dr. Ajay. Today we will discuss about the JIPMER question, JIPMER exam ENT questions. This is a ENT recall questions again, as I say whenever I present a PowerPoint or present a slide in the discussion. This is a recall question. This is not the exact question given in the exams. Okay, and hope most of you have given the JIPMER exams. And compared to last year or compared to the AIMS or PGA, JIPMER was a bit easier than the other exams. Okay, and the ENT part, as of every year, the JIPMER ENT questions will be mostly like a direct one-liners or a straightforward MCQs, and this year also it happened to be the same. There was not much difficult, and I hope you guys would have answered this 7 out of 7 or maybe whatever the question which I missed, whatever the ENT questions, I hope you all have answered easily. Okay, so coming on to the questions. The first one, the most common type of otosclerosis, a very easy one. Okay, and a repeated one also that was asked not in JIPMER but in other papers. The most common type of otosclerosis. Okay, so this question was asked on the types of otosclerosis, which depends on the foot plate of stapes. Okay, so we want to know. So it depends on foot plate of stapes. We want to know what are the types of otosclerosis. Okay, so there are 5 types of otosclerosis. 5 types of otosclerosis. One is anterior. This is a picture given in your Dingra book, which you would have read in your pre-final exams. Okay, so this is a anterior, posterior. This is circumferential. Okay, and this is a biscuit type, and this is a obliterative type. These are the 5 types in the otosclerosis. Okay, so anterior type is that involving the anterior part. Okay, so we want to know what is the most common site of otosclerosis. Most common site is fistula antifenestrum, right? Fistula antifenestrum. So this is the most common site of stapedial otosclerosis. Okay, another repeated MCQ which was asked previously. The most common type of stapedial otosclerosis is fistula antifenestrum. So anti indicates anterior. Okay, so the most common type of stapedial otosclerosis, the most common type is, it is an anterior type, not the other types. Okay, so if it is a posterior, the second option is posterior. In the posterior, it is fistula post fenestrum, not antifenestrum. It is fistula post, that is the second most common type. And if it involves the entire foot plate of stapes on the lower aspect, it is called circumferential. And if the foot plate is normal, only the superior part is involved, then it is a biscuit type. And if the entire foot plate along with the part of the stapes suprastructure is involved, then it is a obliterative type. So these are the 5 types of otosclerosis. So the answer for this is anterior type. I hope most of you have got it right. Okay, so the most common type of otosclerosis is anterior type of otosclerosis, and the most common site is fistula antifenestrum, which we discussed, fistula antifenestrum. Okay, so coming on to question 2. Okay, question number 2, again a simple basic one-liner which I hope 100% of you have got it right. Okay, the most common site following a foreign body injection. So we want to know what is the narrowest part in our foot pipe. That's it. So narrowest part, they have asked about the esophagus. So esophagus, as we know, there are constrictions are there, but the narrowest part, the most narrowest part in our alimentary tract or the foot pipe, the most narrowest tract is the cricopharyngeal junction or the cricopharyngeal sphincter is the most narrowest part. So any foreign body taken, maybe a coin foreign body in the children, or maybe some chicken bone or whatever, it goes and sticks in the cricopharynx. If it crosses the cricopharynx, it may easily go down. But cricopharynx is the narrowest part where it gets stuck. Okay, so this is a straightforward one-liner. Okay, so aortic constriction is there, but the narrowest part is the cricopharynx. The most common site of foreign body injection is the cricopharynx, that is the foot pipe, not in the breathing tract. Okay, so coming on to the question number 3. So otalgia, that is a ear pain, can be seen in all conditions except. Okay, so for this we want to know what are the conditions which produce the ear pain. Okay, so any condition in the ear can produce a ear pain. Is there any option like a condition in the ear? Yes. So meningitis bullosa. What is meningitis bullosa? Meningitis bullosa, say, consider this as a tympanic membrane. Okay, meningitis bullosa is nothing but the tympanic membrane because of mycoplasma infection. Okay, it is caused by infection, mycoplasma pneumoniae. Okay, so because of mycoplasma infection, okay, the tympanic membrane, there occurs some bleps along the tympanic membrane. These bleps will produce a severe earache, and this condition is called as meningitis bullosa. So meningitis bullosa can produce a ear pain. Okay, so ruling out that option. So what other conditions? Can a TMJ arthritis can produce a ear pain? Can a nasal polyp can produce a ear pain? Can a dental caries can produce a ear pain? So for this, you want to know these three are not conditions of the ear. So they are asking something about referred otalgia. Referred, that is a ear pain which is referred from one area to the other. So what are the nerve supply of the ear? So we want to know what are the nerve supply of the ear. So what are the nerve supply of the ear? So what are the nerve supply of pinna? Pinna, as we know, pinna is supplied by 5 nerves. The most is the auriculotemporal nerve, right? This we all know, auriculotemporal nerve, which is a branch of, auriculotemporal nerve is a branch of mandibular division of trigeminal nerve. Clear? It's a branch of mandibular division of trigeminal nerve, that is 5-3. Okay, so the next one, what are the other nerve supply of the pinna? Next is a greater auricular nerve. Okay, and the third one is lesser occipital nerve. These three are the main nerve supply of the pinna. So the greater auricular nerve, lesser occipital nerve, both are supplied by cervical plexus. Okay, that is C2, C3 and C3, C4. These are by the cervical plexus. Okay, so what are the other nerve supply? So the next one is either there can be a vagus nerve. Vagus nerve is called as auricular branch of vagus nerve is called as Arnold's nerve or Alderman's nerve, right? Or there can be a facial nerve, right? So what is these are the nerve supply of the pinna or the external ear is concerned. Okay, what is the nerve supply of the middle ear? Nerve supply of middle ear, ninth nerve, glossopharyngeal nerve. What is that nerve called as? Jacobson's nerve, right? So the nerve supply of the ear consists of auriculotemporal nerve, which is by the mandibular division of trigeminal nerve, greater auricular, lesser occipital from the cervical plexus, and the vagus nerve, otherwise called as Arnold's nerve, otherwise called as Alderman's nerve. Arnold's nerve or Alderman's nerve is a auricular branch of 10th nerve. Okay, it again supplies the external and the middle ear. Facial nerve supplies the floor of the external and also goes to the middle ear, and the middle ear is supplied by Jacobson's nerve, which is a branch of glossopharyngeal nerve. Clear? So coming on to the options now, TMJ arthritis. So temporomandibular joint. Temporomandibular joint is supplied by which nerve? Temporomandibular joint, this area will be supplied by mandibular division of trigeminal nerve, right? So the dental joint, TMJ joint, or somewhere in this area, the jaw, everything is supplied by the mandibular division of trigeminal nerve. Okay, so TMJ, will it causes referred otalgia? Obviously yes. What I said, auriculotemporal nerve is a branch of mandibular division of trigeminal nerve, so it causes referred otalgia. Okay, dental caries, again what I said now, dental caries, any problem in the dental cavity, again it is supplied by the mandibular division of trigeminal nerve, so it can cause a otalgia. So can a nasal polyp can produce a otalgia? So nasal polyp, we want to know, nasal polyp can produce a ear blocking sensation if it goes and extends up to the nasopharynx. It can block the eustachian tube, can produce a ear blocking sensation, but ear pain due to polyp does not occur. So in a nasal polyp, okay, what is the nerve supply of the nose? It can be either nasopalatine nerve, it can be either an anterior ethmoidal nerve, whatever. Okay, these nerves are not in concern with the ear. Okay, so the answer for this is, except the answer is obviously option C, which is nasal polyp. Okay, the question can be even a bit different. Okay, they can give a neck pain in the option. The neck pain, can it produce a pain in the ear? Obviously yes, the neck pain, it can produce through the greater auricular or the lesser occipital nerve. It can produce a pain in the ear through the cervical plexus, or they can give a pain in the throat or pain in the tonsillar fossa. The pain in the tonsillar fossa can get referred through the glossopharyngeal nerve, right, or they can give a pain in the larynx area. The pain in the larynx area can get referred to the ear through the vagus nerve. So we need to think and answer what I said, 5 nerves, right. One is the auricular temporal nerve, which is by the mandibular division of trigeminal nerve. Just have it in mind, mandibular division doesn't concern with the ophthalmic or the maxillary division. It is the mandibular division of trigeminal nerve, cervical plexus, vagus nerve, glossopharyngeal nerve, okay, and the facial nerve also supplies a part. Okay, so these are concerned with the referred otalgia. So coming on to the question number 4. Again, a straightforward MCQ. A patient presented with hoarseness of voice to OP. I hope the question was not the same as what I am pointing, but the content is same. Okay, what they asked, a CT was taken which showed a tumor or some growth along the tracheoesophageal area. So tracheoesophageal area, there is some tumor. So which nerve is most likely injured? So which is the nerve which runs along the tracheoesophageal groove? So which is the branch? So all the options which were given point towards the branches of 10th nerve, vagus nerve. So which nerve runs along the tracheoesophageal groove? It is option A, which is recurrent laryngeal nerve. A very easy, straightforward MCQ, multiple time repeated in ENT, multiple time repeated in surgery. It runs in the tracheoesophageal groove. Okay, so what are the other nerves where it runs? So the vagus nerve, which comes from the vagal foramen, it comes along the nucleus ambiguous. Okay, it comes down, gives a branch which is a superior laryngeal nerve. Okay, the superior laryngeal nerve further divides into the internal laryngeal nerve and the external laryngeal nerve, right. So these two are branches of superior laryngeal nerve. Now the option, even if we get confused, the answer is straightforward, the rectal laryngeal nerve. So superior laryngeal nerve further divides into internal and external. External supplies only one muscle, that is cricothyroid muscle. Internal supplies the nerve supply, sensory innervation just above the thyroid cartilage. Okay, then this vagus nerve runs down and down and down. Okay, and then makes a turn. Where it makes a turn? Along the right side, it makes a turn along the left side, it makes a turn along the arch of aorta. Okay, and the right side, it makes a turn around the subclavian artery. Okay, it makes a turn and then runs upward in the tracheoesophageal groove. Okay, this part is called as recurrent laryngeal nerve. Recurrent, it recurs again, so it is a recurrent laryngeal nerve. So the answer is option A, recurrent laryngeal nerve. So coming on to the next MCQ, question number 5, very easiest straightforward MCQ. What is the indication of test bulb? I am not sure whether these options are mentioned in the exam. Option A was epistasis, and I hope most of you got it right. So what is test bulb? What is test bulb? Test bulb stands for transnasal endoscopic, okay, sphenopalatine artery ligation. So this is test bulb. Test bulb stands for transnasal endoscopic sphenopalatine artery ligation. So sphenopalatine artery ligation. Okay, so where it is needed? It is needed in epistasis. So the answer is a straightforward. It was option A. In your exam, I hope so. It is epistasis. It's a very easy, straightforward MCQ. So transnasal endoscopic sphenopalatine artery ligation. So coming on to the next question, question number 6. So a patient has a knife injury to hypoglossal nerve. So this was more of an anatomy oriented MCQ. The patient had an injury to hypoglossal nerve, maybe a knife injury or whatever, stab injury, whatever. He injured the hypoglossal nerve. So the question was, which muscle is responsible for deviation of tongue? And the option they gave were the muscles of the tongue. Okay, for ruling out the option, we know all muscles of the tongue are supplied by hypoglossal nerve except palatoglossus, right? Palatoglossus is supplied by which nerve? It is supplied by 10th nerve, vagus nerve, right? So the rest all option. So genioglossus, hyoglossus, styloglossus all are supplied by hypoglossal nerve, 9th nerve, right? So what is the main muscle of the tongue which is responsible? What is the function of genioglossus? The function of genioglossus is, it is the major bulk of the tongue. Okay, the main action of the genioglossus is movement of the tongue, right? Movement of the tongue, that is the main action. So if genioglossus is involved, if one side genioglossus is involved, the tongue will get deviated to the other side. Okay, so deviation of tongue is because of paralysis of genioglossus muscle. So what are the other options? Hyoglossus, styloglossus. Hyoglossus, styloglossus. As the name indicates, the function of hyoglossus, the function of styloglossus is, hyoglossus, it just pulls the tongue downwards. Okay, it just pulls the tongue, not from side to side. Styloglossus again, it just retracts the tongue. Okay, so these two are concerned with the movement which is retraction or lowering of the tongue, not the deviation of tongue. Okay, so the answer is genioglossus. Genioglossus is concerned with movement of the tongue side to side. So any injury to the hypoglossal nerve will produce deviation of tongue is because of which muscle? It is because of the genioglossus muscle. So coming on to the next MCQ, all of the following are true regarding risk factors for invasive mucormycosis except. So as we know, mucormycosis is an invasive one. It causes involvement of the blood vessels, it causes involvement of the nerves, it is angio-invasive one. It is a complication following a fungal sinusitis, and it is a fungal condition. Okay, it is a complication following sinusitis. This mucormycosis, it occurs in diabetics, okay, and immunocompromised persons. So who are immunocompromised persons? Immunocompromised persons are the persons who are on drugs for prolonged periods of time, maybe a chemotherapy, maybe a radiotherapy, whatever, or the patients whose immunity is very poor, that is a HIV or any candidiasis patient maybe, or in a patient with a malignancy, it can be present. Okay, so the question asked was, all of the following options are true regarding risk factors for invasive mucormycosis except. Okay, option A, it is seen in diabetics. I am confused with the option. The option here, the option A, it is seen in diabetics. Is it seen in diabetics? Obviously yes, it is seen in diabetics. So the answer is, it is true, it is not a false statement. They have asked about the false statement. So it is seen in malignancy, not seen in malignancy. What I discussed, mucormycosis is a condition which occurs in diabetics and immunocompromised states, that is the patient who are on malignancy or immunosuppressive drugs, or those who are on HIV patient or candidiasis, whatever. Okay, so not seen in malignancy. Is this a true statement? Is this a true statement? Obviously this is not a true statement, right? So this is a false statement. So the answer is option B, it is not seen in malignancy. It is mucormycosis is obviously seen in malignancy. So coming on to the next one, the next MCQ is a bit difficult. This is a recent MCQ also. Okay, so JIPMER has one, they have given one bit difficult MCQ from ENT. So what they have asked is, which of the following is used for the assessment of vertigo, and they have given some questionnaire kind of thing. Okay, so which of the following is used for the assessment of vertigo? Okay, so option A or B or C or D. So I will explain it. So option C is the answer. Option C is the answer. C stands for, the hint stands for nothing but, hint stands for head impulse, N for nystagmus. So head impulse, nystagmus, and T for test of skew. So this hint score is to detect the 3-point oculomotor score. Detects the oculomotor score. That's the 3-point score for detecting the nystagmus. Okay, so the answer is option C, which is hint score. Okay, so what does MIDAS stands for? MIDAS is nothing but it is MI, migraine disability assessment, migraine disability assessment index. Okay, this CHAD-VAS2 is concerned with the atrial fibrillation. It is more of medicine question, more of atrial fibrillation. ABCD2 score is again, it is concerned with the clinical examination, that is A for age, B for blood pressure, C for clinical features, D for diabetics, and D for duration of symptoms. Okay, not important here in ENT. Okay, so the test for assessment of vertigo in the score is hint score. This is a recent MCQ for the toppers, maybe they would have given, but a very difficult one also. So hint stands for head impulse, N is nystagmus, T is test of skew. These detects the oculomotor test to find out the assessment of nystagmus. Okay, so coming on to the end of our topic, so hope most of you have got 7 out of 8 correct. If you are a topper, you would have got 8 out of 8 correct, no issues. So if you have any doubts regarding in ENT or regarding this JIPMER MCQs or whatever, you can WhatsApp me in this number, or you can join my Facebook or a Telegram page, which is Dr. Ajay's Exploring ENT. Which is my official Facebook and the Telegram page also. Thank you.